And Jeff, we've seen your name, but we haven't heard your voice yet. Are you on board?
I am present.
Wonderful, wonderful. Okay, well, let's hope Robert joins us quickly. And but with that, I would like to go ahead and open the April 6th OEB Strategies on Evidence and Outcomes Work Group meeting. We are doing this virtually. It's 9 o'clock, and again, I'll call the meeting to order. You have an agenda and a packet. Rose, I think you're driving our bus. What we have as our first business order of business is review of the March meeting synopsis and then discussion and approval.
So moved.
Second.
Great. All in favor of approving the synopsis, say aye.
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 Okay, and it's approved. So we're now on to the, I'll just do a quick review of what we're doing today. This is our annual evaluation of both cost and utilization for the medical plans. And we compare the previous year, which in this situation was October 18th through September 19th, with the current period, which is October 19th through September 20th. We have basically an hour and 45 minutes. So it really gives us time to understand, as I had asked Willis Towers Watson earlier, to look at ways for us to understand how this information is now being used for our conversations we'll have in the afternoon around rate setting. We'll have a break, and then we'll spend an hour or so talking about our two of our wellness, our major wellness interventions, WW and Healthy Team, Healthy You. There's changes that are being proposed for both. In the agenda, it says that we have an action item. I've taught Glenn and I talked yesterday. The action is that we need to either approve the proposals, or if there's things that we need to have where we change or something, that we need to be very specific about that. Glenn, we need to have that finalized by and approved by the board in June, would you say?
The HTHU, yeah, I mean, we can, I think, go to June on that. For the WW, that's got to be today.
Okay, good. That's good to know. So we will make a decision on WW today, and the Healthy Team, Healthy You conversion to WebMD platform. We have a little bit of flexibility. We can also accept the proposal. That's also an option. Okay, so with that, we are ready to jump into the annual cost and utilization review. I know that I've just talked with Doug. Welcome. I assume Brad and Jenny are with us also.
I'm here, but I think
that's right.
Kick us off.
And
yeah,
you know, Tom, I was planning to kick this off and talk a little bit about it. You did such a great job, though. It's probably not super necessary, but for those that haven't really been, involved in this work group in the past, or maybe missed the meeting, this is the time of year where we walk through both of the plan performance of both OEB medical plans, both Kaiser and MODA, and take an in-depth look at, some of the membership and demographic data, performance of the plan from, both a per member and an aggregate cost perspective. We take a look at trends and key drivers, and then we dive into, cost and utilization data, as well as some of the top condition drivers and so on and so forth. And we have Doug Borlier, who heads our data analytics practice in the Western U.S. and he is going to be walking through this report with us today. And Doug, I may have sold you short in your role, so.
No, that's fine. I also lead our national data cooperative effort. Good morning, everybody. I'm Doug Borley. I'm an actuary in Seattle.
And I see that, Robert, you've joined us.
Yes, thanks.
We have the full. You have the full SEOW committee listening on. So that's the last interruption. I'm now muting.
You'll turn that department over to me, Tom.
Yes.
Take it away, Doug.
Sounds good. Like I said, I'm Doug Borlier. I'm in Seattle, and it's nice to be with everybody virtually. I sure wish I could be with everybody in person, but hopefully that'll happen one of these days pretty soon. I do lead our national data cooperative, and OEB is part of that in how we utilize the data warehouse and do a lot of the aggregate performance review of the medical and pharmacy and dental plans. So as Brad and Tom have both said, this is our annual review of the primarily the medical plans with a little bit of pharmacy data put in to kind of round out the cost picture. If we can look at page 3 really quickly, this is an overview of the contents of the report and what I'd like to talk with you all about today. To start with, we've pulled together and refined our executive summary to really be a 3 or 4 page review that can almost stand alone and provide the information both in a graphical format and also cover the key points that I think any health plan should be looking at. It's not just looking at the places where you're doing particularly well or opportunities for improvement or reviewing specific programs. This is the comprehensive set of information to look at with respect to your population, with respect to how they're consuming healthcare, with respect to their conditions and other attributes that are leading to their health, which is driving the utilization, and then finally the cost. So that's we'll give you kind of a walkthrough of the plan performance at a high level with the executive summary, and then dive into some of the details. So if we can go to slide 5, and just really quickly, this is an outline of why do we pull this report together and why is the information important, and a little bit of narrative about what we're looking at here. Like Tom said, we're looking at primarily the review of the MODA and the Kaiser health plans, with MODA representing about 3/4 of your membership and Kaiser about 1/4. So it kind of puts that into perspective. Some of the key changes that could impact performance and things that we're going to be watching are really the continued focus on the coordinated care management. Kaiser is kind of by definition that type of an arrangement, and then the MODA plans are really seeing a large increase in the number of people that are participating in those coordinated care management programs. So the transition has gone from, with MODA, from the Summit and Synergy programs and the PPO to really having the kind of the triple option among all the plans, where there's a coordinated care option, a standard PPO option, and then there's also the option to get benefits out of network. Fertility benefit came into play, and then the 200% of Medicare reimbursement cap for hospital charges is in play as well. We're not going into great detail on pharmacy because there was already that fairly in-depth report back in February at the SEOW meeting. And then finally, of course, with the impact of COVID, that's had some interesting impacts on most of the clients that I work with, OEB being no exception, showing kind of that classical dip in the March and April, and then some of the cost and utilization kind of coming back to normal, but a few high cost claimants in there that have impacted cost and utilization, and we'll see the effect of that. We did do an in-depth preliminary review of the impact of COVID 2 or 3 months ago, and we've got a couple of the slides from that in here just to remind folks and for reference. So if we can go to the next slide 6, please. So a couple of pages from the executive summary with the key points. I always like to start off by looking at, all right, how many people are we covering? What benefit programs are located or they're enrolled in, and what the total spend is. So this first slide shows the membership in the center between Kaiser at the top, the MODA coordinated care in the center, and kind of the a statistic around the combination. So you can see you've gone from a little bit over half to almost 3/4 of the OEB population being in some kind of a coordinated care system. And then at the bottom is the MODA non-coordinated care, which now is representing about 1/4. And then you can see on the right the total spend, getting toward $750 million, $767 million. Those are dollars in millions, with the top section being the spend for Kaiser, and then the bottom section being the spend for MODA, and then over 3 years' time. At the far left, we kind of say this every year that the populations are very stable, and that continues to be the case. Kaiser still is attracting a slightly younger group and has fewer dependents, as indicated by the family size. But all in all, the plan membership is stable, and if I were to sum it up, we continue to say the performance of the plans ends up turning out to be really good. And that's always a good story. So it's a matter of looking for areas to improve. It's like making a good thing even better. It's not finding a big crisis and saying, "Oh my gosh, we've got to run around and find a solution for a horrible problem." It's evolving something that's working well into something that's working even better, and that's really kind of a nice message to be delivering consistently. At the bottom, we look at some of the key areas of healthcare consumption. So looking at inpatient admissions, emergency room visits, and office visits compared to benchmark. So prior year on the left, current year in the middle, and benchmark on the right. So those are kind of the three areas. If you're to look at 3 things around consumption of healthcare that typically drive cost. And the story for OEB is inpatient admissions are, well within, they're under benchmark. Anything below 50 is really good. And, you're running in the kind of the mid 40s, and that's great. Admissions per 1,000. Similarly with emergency room visits, anything under about 175 is great. You can see the benchmark is even up over 200, and OEB is running at or below 150 emergency room visits per 1,000, and that's also really good. Office visits are ticking up a little bit, and we have that gray because we kind of, starting with the CCM 360 with MODA, we expect to see an impact of that over the next few years. So we've got that gray because that's something that we're going to watch as that improves. But I mean, the office visits, people are getting in and getting their care, but we want to watch the impact of the coordinated care over the next few years and see how that plays out. So this is kind of an early indication. If we go to the next slide, slide 7. I'm sorry, go ahead.
Quick question on the outpatient visits. We include the telehealth visits into that total, correct?
Yes.
Good. That's all.
Yeah. And I can talk a little bit more about that later, because sometimes the telehealth data gets a little bit blurry, especially in the COVID time because a lot of providers that would normally see patients in the office were able to do telehealth and bill for telehealth during the COVID time. So, but yes, that's all included. All right, the next slide, 7, is looking at cost. And up at the top, we're looking at contributions to the change in cost or trend. MODA, the change in cost has gone down a little over 6%. Kaiser has gone down a little over 1%. And you can see that this is broken out by use and price for pharmacy, for outpatient, and for inpatient. And we really expect to see the outpatient going down, and a lot of that's driven by COVID in that 2 or 3 months where utilization was down overall. Inpatient is driven partly by we did have a few high cost claimants that skewed that a little bit. So especially on the Kaiser side, that's why that inpatient price is over on the right. It's kind of a large increase. And the price is just calculated as cost per admit. So
and Doug, this
yeah.
is the one that when I saw it, I thought, boy, that's a little strange because the 1920 plan year is the one that had the impact of the 200% of Medicare. So it had to have been case mix that changed to have these increases.
Yeah, it really was, and it was a small number of people and some very high dollars.
Got it. Yeah.
That skewed things.
Okay, thanks.
Yeah, I think it's also worth mentioning that, from the 200% Medicare, we did expect to see and did see the biggest impact on outpatient rather than on the inpatient side. So that's kind of plays out on particularly on the MODA data.
Okay.
Yeah, that's a good point. So then down at the bottom, we have an illustration of the per member per year total costs. On the left, looking at MODA and then looking at Kaiser, and you can see the total decrease. We have medical, pharmacy, some care management, and then also incurred but not reported factored into the MODA. Kaiser is all on a paid basis because of data timing. And then on the bottom right, you can see the plan paid versus member paid. So the cost share for both MODA and Kaiser. So the member paid is not member contributions to the plan, to the rates. That's member paid in terms of co-payments, co-insurance, that type of thing that's directly related to the medical bill. And then finally, for the performance dashboard, so we've talked about using services, we've talked about overall cost. Now we look at the health aspect. So this is an illustration of the top overall conditions and then the overall chronic conditions. So if you just took all the data and looked at what people had claims for, whether they were acute, chronic, whatever, that's the table on the left, starting with cancer and moving down into diabetes, infections. Those are often things that happen in the hospital, and then maternity and pregnancy and depression. And then over on the right are, and these are classified within the data warehouse as chronic or manageable conditions. So things that you're expecting to see over and over in specific programs. You can address and manage the cost and the care for these things. And cancer, musculoskeletal for both MODA and Kaiser, and diabetes and depression. Those are kind of the top 4, and that's not unusual to see in any employer population. Bottom left is a look at the high cost claimants. really the key thing to look at if you want to take a quick statistic and monitor how the plan is doing with respect to high cost claimants is looking at the percentage of people and then the percentage of dollars that they represent. So MOTA, that's about 2% of the people and about 34 or a third of the cost is attributed to high cost claimants. We're defining that here as $50,000, and the reason we set that at 50,000 is because there's a lot of benchmark data around there, and I know there's you can make the argument, it's like, why not set that higher? Why not escalate that? Because $50,000 starts to erode as inflation takes away, but it's because there's a lot of benchmark data around that. And then for Kaiser, it's about 1% of the people and about a quarter of the cost. Usually we see, so that's actually looking pretty good. Usually we see about 1% of the people driving a third of the cost. That's kind of like a bogey, and with typical mix of chronic and acute stuff and things that just happen. So, in spite of the fact that there were some super high cost claimants that skewed results this year, overall, the statistic looks pretty good. And then over on the right, you can see what those high cost claimant conditions were.
So Doug, Jeff
Yeah.
here. Bottom left, why are you not doing 1% to 1% or 2% to 2%? It's kind of like those are mixed statistics.
Yeah, it's because we do it at $50,000. So it's saying that 1% of the people for Kaiser, for example, is over $50,000. And 2% of the MOTA people are over 50,000. So we hold the dollars constant rather than the percent constant.
Okay. It'd be good to be able to note that.
Good point. Good point. And like I said, the reason is that's where a lot of the benchmark data is. We can always look at it. We can always cut it different ways and look at it as far as what OED looks at. But yeah, it's a good point.
Yeah, and with it being 1% and 2%, that could be KP could be 1.4%, and MOTA could be 1.6%, and
Yes.
And it looks like it's a 50%. It's a 100% difference, and yet it could be 10 or 15% difference. So actually having that one additional digit would be helpful.
Yeah,
I agree, Tom.
good point. And
Doug,
so
this is Bill Grubb.
Yeah.
I was going to wait to the end, but since we're paused at the moment, can you go back one slide to slide 7? And I'll just ask my question now. So
Sure.
on the bottom right, cost share per member per year. Do we have the ability for the future to break the MOTA plan down to CCO plans and non-CCO plans to see how that's
Absolutely.
working?
Yep.
Do we have that data now for this year's analysis?
We might have it later on. I can't remember if we've got it on one of the pages because we were kind of looking at some of the exhibits that were getting too busy, but we do have the data readily available.
Okay, I was hunting for that. I wanted to see how that change is panning out as more people migrate to CCO. Thanks.
Yeah.
That's a really good point, Bill.
We can certainly add that, and easy to provide as a supplement too.
Yeah, if it's not later on in the report, could you do a supplement in June, perhaps?
Yep.
Great, thank you.
Certainly can.
Good catch, Bill.
I'm making a note right now. Excuse me a minute. Okay. Great. The last page in the executive summary, slide 9, is kind of a spoiler alert for the winding up the presentation today, but I think it's good to put it up here. Really, the summary is around the care initiatives, and that I think a key takeaway is right now with the coordinated care for MOTA, that's made that population go from a little over half when it was Summit in Synergy for MODA, and then including Kaiser to almost 3/4. So you've got about 3/4 of the OWEB population overall in some kind of a coordinated care plan. And I think I think that has been the goal, is to get as many people as possible into that type of a plan. So that's kind of the first wave of migration with those initiatives at MODA, and that's looking good. As we're looking at office visits.
This is Robert. Following up on what Bill said, it'd be great in the future if we could have benchmarks to show. I mean, we've had this goal of putting people into the CCO plans, and it's working. It'd be great to see how that impacts various benchmarks, that we normally look at on the health of, of our system, or that it's actually driving costs down or maintaining costs, to show the results of, what we're doing.
Yeah, and I think we can look at that. Sorry about the dog in the background. We can we can track that over time, and we can also look at that. Really, the large benchmark data sets that are out there are PPO versus HMO, and so we can take a look at it both with respect to each of those, which would kind of show the migration, and also if there's some kind of a target that OWEB is looking at specifically, we can show progress toward target. Say the target is getting 90% of the people there, then we can show that progress toward a target like that. But I think that's worth talking about, how to best show that and then measure the progress against some of those goals. But with the first year of data, we're
Ali, did you have a question?
Oh, sorry.
Just quickly, just a comment. I just wanted to clarify that I've heard CCO plans mentioned a couple of times, and those are actually the Medicaid plans. What we have is CCM plans, coordinated care model plans, and that was all. Right. Yeah, thanks.
I'll try to just say coordinated care. I work with a group here called the CCMU too, so sometimes I get my acronyms if my brain gets ahead of my mouth, or my mouth gets ahead of my brain. But initially, we're seeing some really encouraging signs in the data, like the coordinated care members' office visits are increasing, which I think is the goal, to at least get people in for their regular and routine care and wellness visits. And with the idea of getting that regular contact with a primary care physician. So initially, the data is showing that it's accomplishing what is intended, and then it'll be, as the experience plays out, it'll be interesting to see the overall impact on other types of services, like use of urgent care versus emergency room, use of, going to the doctor's office for, pre-consultation before other types of services, and how well some of the chronic conditions are being managed. As we said, the COVID-19 has had a big impact on the results. We've talked about, we did do a preliminary analysis on that a couple of months ago. It has had an impact on the 2019 and 20 results, as we look at especially some of the details of utilization, which are down. Overall costs are down. So, as we're coming out of that, what we are seeing and what we're recommending to a lot of our clients is making sure that there's really strong communication about getting back in to make sure that some of the basic preventive screenings are happening. So we'll be watching that, the cancer screenings, the women's health, and then overall visits with a doctor. And hopefully the coordinated care is gonna help with that. There are a couple of other initiatives with the integrated work group, centers of excellence around managing musculoskeletal. I think the work group is also looking at monitoring the impact of the cap on inpatient and outpatient hospital. And I think Brad may have a couple comments about that later. And then expanded fertility expanded fertility benefits being implemented. There's not a whole lot of experience on that for this year, but we'll be watching that in future years. So that's the executive summary, which is really the kind of the meat of the analysis that that comes after. I want to pause for just a minute and see if there's any other particular questions that people have, and that'll kind of guide how we go through the details. I don't want to go through every single page and every single number in the rest of the report because we'll be here all week, but I do want to hit the highlights, and I want to hit things that people are particularly interested in. So I want to pause for just a minute and see if there's any questions.
In terms of process, for the next half an hour, it probably would be best for SEOW members to maybe write down questions, and then so we'll be quiet as you kind of go through areas, and then we can go take on people's questions or comments as we in the question part. Is that okay with the rest of the SEOW members? Silence is agreement, so we'll go ahead and.
All right, I was on mute. That's fine with me.
Yeah. Okay. All right.
Okay, sounds good. Let's go to slide 11 really quickly. If you're looking through this at some point and wondering exactly what's in the report, where the data comes from, this is a summary showing the years that we're looking at, outlining that most of the data has been pulled from the IBM Watson data warehouse, and that we do take time to review the results with folks from both of the carriers. We've already talked about some of the key benefit changes, but those are outlined in a little bit more detail here. So let's start with some of the details around membership. If we take a look at slide 13. The keys here are really showing the counts and the numbers that are enrolled in the coordinated care, the non-coordinated care for MODA and Kaiser, showing that the overall counts and numbers and the split between MODA and Kaiser is fairly constant year over year. And then finally, in the bottom right, the illustration of kind of the decrease in the number of people in the baby boomer generation over on the right, and then starting to see the stability of the Gen X people, and then the increase in the millennials on the left. So if you kind of look at the percentages going from back to front, you can see that an illustration of that migration, and that really impacts how I think it impacts the approach to how benefits are designed, how communication programs are rolled out, and really how you look at who is consuming what kinds of health care. And also might be a way to think about anticipating what some of the chronic conditions that may be coming up, and what kinds of acute things that you might be seeing too. So for example, if you kind of look at the characteristics of how baby boomers versus millennials spend their free time, you might think that there would be maybe an increase in some of the acute stuff from the invincible millennials doing their crazy triple black diamond downhill skiing and stuff like that. But that, I don't mean that to be flip. I mean that to say that, all right, maybe that is the time to think about things like complex care management for acute conditions, as well as looking at things, chronic stuff like the cancers and the diabetes and conditions like that. So that's a summary of the people that are being covered. The next slide, 14, is looking at a little more detail around the those little donuts that were in the around the high cost claimants that were in the executive summary. So we've got a little bit more detail around the claim levels in the graphs at the bottom. So these are percentage of people versus percentage of claims, and we have it broken out to the low or the under 5,000, the medium 5 to 50, and then the high 50 and up, and then the percentage of non-users in the left bar, which is running between 13 and 20%. So you've got a pretty good percentage of total population that is actually touching your healthcare programs in some way, whether it's a pharmacy prescription or a doctor's visit. The one thing I wanted to say about this too is normally we take a pretty detailed look at risk scores over time. That's kind of the one number that indicates the risk of future cost for the plans. With COVID, that's really kind of screwed up claims patterns, and so looking at the risk scores get a little bit wonky with the experience during the COVID time. So we'll be monitoring that and probably getting back into a more period over period review of the risk scores for the next report. Right now, just kind of know that they're there. We're looking at it and really don't want to draw too many conclusions out of risk scores at this point. Normally, that's kind of like the one number that you kind of look at to monitor the overall health of the people in your plan. But like I said, with the COVID data and the claims patterns that got kind of crazy this year, the risk score numbers get a little bit unreliable. So let's take a look at overall costs. And if you look at slide 16, right there, we've got a 5-year history of per member per year costs. And with the current year, we've added a component for the incurred but not reported to try to get everything on as much of a apples to apples basis across time as possible. You can see over on the right-hand side that adds an extra $82 per member per year. But this is looking at medical, which is the lower
I lost sound. Did anybody else?
Me too, about a minute ago.
Yeah.
Yeah.
Yes.
Me too, Tom.
Bill, we lost sound from Doug.
Ruh-roh.
In fact, it looks like his screen is frozen.
Frozen. Yeah.
Sorry about that. Can you guys hear me now?
You're back on.
I apologize. Every once in a while, our internet connection at home here drops out, and
You were just starting the per member per year annual costs and said that you're allowed to make it apples to apples.
Yeah. So what I was starting to say was that we add the incurred but not reported piece on the current year to make it apples to apples across the 5 years. So we're looking at the medical costs, which is the bottom bar, and then stacked on top of that, the pharmacy, and then the care management piece, which is primarily a Kaiser number that's added on, and then the incurred but not reported. So you can see the pharmacy has increased a little bit. You can see the medical has dropped almost 11% in the last year, and a lot of that's due to deferred care or just eliminated care throughout COVID. And then we have the care management and the IBNR on top. So that leads to the overall about a 6.3% decrease for MODA. I'm sorry, I said the care management for Kaiser. That I meant for MODA. We have a similar exhibit for Kaiser in a couple of pages, but the next slide shows the coordinated versus non-coordinated care costs for MODA. If you look at the prior 2 years, that's basically the Summit and Synergy, and then the current year is with the coordinated care, the CCM 360. You can see that the costs are a little bit higher for the coordinated care for the current year for MODA, and we're kind of right now we're watching that, but that's probably a good thing because we want to make sure that people are encouraged to get into the doctor, and so seeing that that's higher for the coordinated care is probably what you want to see. Usually for when you're migrating to something like that, you'll see a spike for the first couple of years as people get caught up on their care, get caught up on their medications, and then things start to stabilize. So, we're seeing that as a positive sign.
Yeah, and just as a reminder to the work group, that was one of MODA's key objectives in implementing this program, was to get more of the high cost members that really needed care into a more managed setting than they were under the prior program. So,
right.
Seems to indicate a successful result there.
And then if we look at the next page, we've got similar exhibits for Kaiser, looking at the costs overall. And again, the medical on the bottom, pharmacy in the middle, and then the integrated care piece on the top. So overall, a little over 1% decrease, and then the changes in the medical and pharmacy and integrated care. And here we did see a decrease in the medical for Kaiser as well as MODA, a little bit less of a decrease, but a decrease nonetheless. And again, likely pretty much driven by COVID. Kaiser did have some high cost claim experience and this is one of the places where that comes into play. And so if those high cost claimants were removed, we'd probably see a much more significant drop in the medical costs. So that's how a few people can have a pretty good size impact. The next slide, 19, is it's pretty much the information that we saw in the executive summary about the cost share, with Kaiser being about 90-10 and MODA being about 80-20 in terms of what the plan pays and what is in the plan design for co-insurance and co-payments and other member paid amounts. So that's it for the overall member and cost. Now we want to move into some of the trend drivers. So looking at
actually,
oh, go ahead,
Doug. What I'm going to do, we'll divide this up into sections. Does anybody have any committee members have any questions for Doug about what we just went through in terms of the risk scores and CCM and cost information?
He answered my questions.
No, for me.
I'm good.
I had one.
Sure.
I agree that the goal of MODA with switching the CCM, to the CCM focus used to be just cost basis, and so people who had lower medical costs, kind of went to the Summit Synergy product because they could save costs. Premium costs, and they weren't utilizing that much, and the higher cost people kept with the PPO. And so this really is shows the importance of changing the approach to to their CCM product. My question is, do we have risk scores that document that switch from, lower risk previously in the Summit Synergy now to the higher risk in the CCM product? We don't need to have an answer to that now, but and it sounded like just before you said that risk scores in the time of COVID are wonky, but that would kind of just, if we're able to get that data, it kind of justifies or the effort that Moda made in this regard.
Yeah, and that's an excellent point about watching, and that's something that we when I analyze the impact of some of the care programs and even things like on-site clinics, the idea of meaningful care is, are you getting the people that really need to be seen? Which, at a first glance, it's the people with the higher risk scores. Are they taking advantage of those programs? And I think that concept exactly applies here with the coordinated care. You're right. We don't have the reliable risk scores for the COVID year, but that's something that we'll certainly
follow
put in for the
follow
future
over
years.
time. Yeah.
Yeah.
Great.
And following that over time and watching that, the ideal would be to show that trend up, and then it's probably going to level off. But as you see the PPO, both the counts and hopefully the risk maybe either leveling off or decreasing a little bit. That would be the ideal situation.
Okay, thank you.
I know sometimes PPOs are sticky with the older at-risk populations just because it's carriers that they're used to. But I think the fact that the plan design is such that there's a coordinated care component across all the plans, that may really help that situation.
Thank you.
Yeah. So our next section is looking at components of trend. We had a look at this same page 21 at the beginning, and we really talked about the key thing here that, especially with Kaiser on the inpatient price, there's a pretty significant impact of some high cost claimants. And then also with decrease in the outpatient use, there's a COVID component there too. So this is a breakout of what's happening with pharmacy, outpatient, and inpatient, and showing that that decrease a little bit over 6% overall for Moda and slightly over 1% for Kaiser. So breaking it out into those components. So then if we look at where the service cost is, slides 22 and 23 break out inpatient. I just want to point out something here on both 22 and 23. So for Kaiser and Moda, there's been a change in how the dollars are being accounted for with inpatient. And now they're pretty much all going toward in the room and board section. So that's why there's a big increase there. We wanted to show the raw data as it's coming across, but this is really looking at the impact of more of an accounting change and a tracking change rather than a use change. So there hasn't been a huge increase just in room and board charges. It's just that the total hospital charges are grouped within the room and board category. I think it's more interesting to start looking at the inpatient utilization. So if we look at slides 24 and 25 for Moda and Kaiser, we can see that utilization is down pretty much across the board, and that's really the impact of probably a lot of care deferral with COVID. People just have been deferring, some of the inpatient services, and then the associated ancillary stuff like the lab and the injections and emergency room and things like that are also dropping. The next section is looking at overall utilization. I want to go through this a little bit quickly because we've talked about some of the major components in the executive summary, but I do want to talk a little bit about the coordinated care piece. So if we look at slides 27 and 28, we talked about the we talked about two of the four key areas: the inpatient admissions, emergency room visits. We also have the lab services and radiology to go along with those. If I were to expand from the two or three to a few more, I'd bring in lab and radiology because there's often a lot of variation there. But the trend for both MODA and Kaiser for all four of these utilization statistics, inpatient, ER, lab, and radiology is generally in a downward direction, generally way below benchmark or well below benchmark, and so those are humming along nicely. Certainly no concern there. And even looking back before pre-COVID, the trends have been the same. So it's not like, okay, we've got an aberration because of the COVID year and things are out of whack next year. No, that's been the trend for a while. Starting on slide 29 and looking at also at slide 30, this is where we're starting to monitor, and really I'd be hesitant to draw any conclusions yet, but this is where we're starting to monitor and break out the utilization for the coordinated care plans with MODA and comparing that to Kaiser. So kind of looking at that whole coordinated care picture across MODA and Kaiser together. You can see that really the inpatient admits, ER, and radiology inpatient admits and ER are pretty similar. Lab and radiology may be a little bit higher, but again, this is here because we want to start looking at these and look at the coordinated care by itself. If we look at slide 30, similarly with office visits, again, the goal, and here's kind of neat. If you look at the far left bar, and then if you look at the third bar, the purple one with the dots, and then compare that with the fifth bar, the blue one for Kaiser, you can see that those office visits for the MODA coordinated care and for Kaiser rates are very similar, and they're quite a bit higher than the MODA non-coordinated care. So that's probably the first place where you're going to see some impact is with the office visits, and you're seeing it. And we'll be monitoring that on an ongoing basis. So people are getting into the office more for the MODA coordinated care, and that's so preliminary look at what's happening, and it's looking like it's going in the right direction. We did include some information on telehealth, which is actually the same. This is a slide that we presented to SEOW in March around utilization of telehealth with COVID, and looking at kind of down at the bottom left, the big decrease in in-person office visits, but the large increase in telehealth, with combined the two being down a little bit, but telehealth really took up a lot of the slack. And over on the right, you can see that that kind of spike in telemedicine for both MODA and Kaiser. But again, that's a repeat of information that we had back in March, but we wanted to put that here in the report, so it's there for reference. We've got a couple of other pages from the COVID analysis that we did in March too, a little bit later. But Tom, that I think you had the question about telehealth earlier. And so that's one of the reminders there. The last area that we looked at, like we said, we look at utilization, we look at cost, and then we look at conditions. We've got some more detail around the conditions that we talked about in the executive summary if we start on page 33. So this is a chart comparing the conditions for MODA and for Kaiser. And these are the overall conditions, not limited to chronic conditions. We talked about how cancer and musculo are kind of the big ones for MODA. Diabetes is certainly in there as well. Mental health and depression makes its way into the Kaiser top 5. I think it's about number 7 on the MODA list, something like that. So that's definitely, and that's that's an issue across every single client that I'm looking at. And this year, I was actually, well, maybe I wasn't so surprised because we didn't have the full COVID year, but we're starting to see a big impact or a big uptick in, especially toward the year end of 2020. And remember, we're only going through the end of September here, but an uptick in EAP use, an uptick in behavioral health claims and things like that. And so that's something that we'll probably be seeing. And a lot of clients that I work on, they're really encouraging taking full advantage of the behavioral health services that are available and using the benefits to their fullest. A couple more of the COVID slides. We've got MODA and Kaiser musculoskeletal. That was an area that kind of across the board, and from our health management practice, we were really getting some good information around is people deferring care for certain procedures that probably weren't emergency, but needed to be taken care of at some point, but generally waiting, through the COVID period. And here you can see for MODA, just as a reminder, that March and April, the musculoskeletal, joint replacements, things like that really dropped in March and April, but started to make up ground, coming out of May, June, July, and then kind of leveling back off toward the end of the plan year. And that was true for MODA. Kaiser, the numbers are really small, so there's a little bit more variation, but kind of similar that you'll see on slide 35. And this was information that we had talked about back in March, but good to just kind of raise again and have for completeness here. Slide 36 is a little more detail around the chronic conditions that we talked about. So number of patients, for example, for MODA on the top for cancer, running about 2,000 to 2,200 patients, and then the total cost for those cancer patients, and then running down the rest of the top 5 chronic conditions or manageable conditions. Similarly for Kaiser down below. Cancer and musculo are the top 2 for both, and diabetes is in there as well. And again, very typical of most employer clients. So the web is certainly not showing anything unusual here. And then looking at detail on slide 37 about a little bit more of a drill down on what those the cancer numbers look like into different types of cancers. We've got a fair amount of cost going into leukemia, for example, and lymphoma down at the bottom. Most of the data that I look at, breast cancer is generally one of the top two. We are seeing a lot of leukemia and lymphoma rising from, they might be number 7, but rising toward number 2, 3, and 4 now. And to round this out, just to give you a picture of how OEB looks with the balance of acute versus chronic. And again, showing this because there's kind of a different approach to dealing with acute. That's more of a case by case, making sure that people get into appropriate, I guess, more shorter term care versus chronic being making sure that people are getting the long-term attention and monitoring that they need. And you can see that slide 38, overall, you're running a little bit higher than half on the chronic. And if you look down below, it's about 50-50 for Kaiser and pretty close to 55-45 for MODA. And then if we break out the conditions, kind of a step, looking at in a little bit more detail about looking at what those manageable conditions are. You can see on the left, MODA and Kaiser. Mental health and depression is, one of the specific ones in there, making sure people are doing some of the basic stuff like looking at hypertension, taking care of chronic asthma or manageable asthma, and then diabetes. This isn't necessarily high cost stuff, but this is relatively high prevalence and fairly straightforward management. And so I guess now that brings us to next steps on slide 41.
I'm going to go ahead before we do next
Shall we
steps.
start?
Let's do
with
some
questions?
Let's circle back and ask any questions about this data dump we just had. And then as we get to next steps, that's where we have our conversation.
Absolutely.
I'll start it off. It was, I'm not surprised at all by the impact of leukemia and lymphoma, even though if you look at incidence, they're much less than lung cancer, breast cancer, colon cancer, prostate cancer. Those have much higher incidence. And yet what's happened is that treatment has been very successful, so those people are kept alive, and their treatment needs to be ongoing. So it's the leukemia patient who, with acute leukemia would live or die with, let's say, a bone marrow transplant. And now what's happening is that there's medication that costs an arm and a leg, but the person keeps alive for years and years. I think the same thing is true with lymphoma with targeted therapy. So not surprised, leukemia and lymphoma will continue to be at the top of the list. It's a success from a standpoint of medical therapy. It's just a very expensive therapy. And the difference between MODA and KP in regards to acute and chronic probably is explained by the younger population. Younger populations in general have higher acute treatments as compared to chronic treatments, which increase as people age and have a higher risk scores. That was my only comment.
Yeah. If we go back to pages 22, 23, and 24, 25, PowerPoint forces different scales based on the numbers. And so visually we get kind of a different perspective. It's most dramatic between pages 24 and 25, where 24 has a scale of 700. And then you go to the next page and it's a scale of 5,000.
Yep.
So it actually delivers visually a reverse message, because out of those 10 measures, MODA is higher on 2 and lower on 8. And yet, if you look at the bar graphs, you could get the opposite. And so I don't know whether the answer is to put them both on the same page for those two things. But it would be helpful if there was a bit more uniformity in scale if we're going to use graphs. The second part is, to Bill's earlier point, is I think we're at a place where we should be measuring Kaiser, MODA CCM, and MODA traditional.
Mm-hmm.
So that would be.
And Jeff, I've already sent Glenn a text for us to start. What we need to think about staff, WTW and MODA is how to start. How are we going to be comparing non-CCM versus CCM? So definitely, this presentation has brought that forward, and we'll have that conversation. Hopefully, have a plan in place by June.
Yeah, I expect that we're going to get more questions from outside on those measures.
Okay, good.
So that'd be very helpful. Thank you.
Yeah.
This is Bill. I'm kind of piling on with what Tom said, but wondering about metrics being the statistics guidance. That, we're looking for a value here. It's not just about dollars last year versus this year. Somehow we have to bring in a value metric here, because some drugs or some procedures can be of higher cost but greatly reduce, remedial care and recidivism type stuff, and our investments into better procedures into the future but cost more now. And those values don't really show up unless they're footnoted or something talked about here. But I don't have an answer, but I somehow value of what we're doing here is got to be thought about as well. That's it.
When I, over the years, there's the triple aim, which includes patient experience, and we don't have good metrics to be able to identify those, Bill, and it has been that's the struggle. But that's the reason why it is so helpful at board meetings to hear, specific constituent responses and complaints that are going to the health plans, going to the entities, going to OEB, and it's a shadow. We're looking at the shadow. We're not looking at the actual impact on people. But figuring that out will be very important, because it's cost and it's quality, but it's also service and how people are responding. We'll have to figure out. We'll have to continue to work on that. Other comments, Robert? Do you have anything you wanted to add? Any issues or you wanted to add to this, or we'll then otherwise move on to next steps?
No, it was all covered. Move on.
Okay, thank you. Okay, Doug, you're on.
Great, and I appreciate the comments about looking at different statistics going forward too, and certainly about things like format and scale, but also thinking about how to look at the coordinated care versus non-coordinated care and splitting those out. So we'll put some thought into that on our end and on how to best do that. Run some ideas past you and see what we come up with.
Super.
So in terms of next steps, Brad, maybe we can kind of tag team this, but I'll start. I think it's going to be important to kind of round out the monitoring of the COVID impact. We'll kind of we will kind of watch what's happening with our clients overall. I mean, we're starting to see things pretty much come back to almost come back to normal, but we're watching this for gosh, probably 200 or 300 clients nationwide right now, and you know, we'll see how that can be relative to OEB's experience. But really, the things to watch for are the impact of deferred care. So making sure that, you know, if somebody put off a joint replacement, that, you know, something acute like that, that they're getting that taken care of and able to both access the benefits and access the facilities, but also looking at making sure that the wellness visits happen. I mean, that's kind of the thing that could get deferred and forgotten about. You know, anything from some of the very specific age, gender appropriate screenings to just general, you know, going in and getting a checkup. And then I think on the other proactive side is, you know, take advantage of the fact that people got used to using telehealth for certain kinds of services. I mean, it's kind of like, you know, having a Zoom attendance option for an in-person meeting for somebody that might not be able to make the trip in. You know, that may be a good sticky outcome of the whole COVID crisis. And then finally, being very proactive about behavioral health and you know, seeking that kind of care. So I think those are some important things around COVID. I think we've already talked about the coordinated care, and, you know, we've got some preliminary information about that. I'm sure MODA will be reporting on that, as well as, you know, we'll be putting that into our ongoing monitoring. And if we can think about the best ways to bring that information to this group and also rolling up to the board. As the fertility benefits have been enhanced and those benefits have changes, those tend to have kind of a longer term showing of results or impact. And, you know, we'll watch it with some key metrics around that, you know, starting out with engagement and then moving toward what's happening with the claims patterns in that area. And I haven't been quite as involved with the innovation work group, but Brad certainly has. But I know there's some ongoing things with musculoskeletal, and then also monitoring the reimbursement cap. So I don't know, Brad, what do you have anything that you want to add around the next steps?
No, I think that was a really good summary. I would just, you know, enhance that comment on the COE just a little bit. We'll be discussing that a little bit more with the, you know, full board this afternoon. And, you know, we are moving towards working through our hospital reimbursement cap reporting. You know, that's something that is on our timeline, and, you know, is part of the IWG. We'll be working through that. And I think we're working through that together with both OEB and PEB. So
Great.
that's all I have there.
A question, the question that I had on this next steps, I missed when you think we'll have data in regards to the fertility benefits, because that started in October 2019.
Yeah, I think certainly by the next annual review, and I think, you know, we can take a look probably over the next 2 or 3 months and see what's emerging. You know, COVID, like with the risk scores and like with a lot of things, it's
you're right.
Messed up the claims pattern. So we don't want to jump the gun and draw conclusions, but we can certainly set up the monitoring.
Yeah, I think identifying it as a year from now. That's fine.
Okay.
But you know, when we add something, we need to go back and you know, because there's projections in terms of what it's going to do to rates. We build those rates in, and then it's good to see actually what happened. The same thing is going to be with transgendered surgical benefit that we may be changing this time, we're going to need, we're building in a rate increase to be able to deal with that. And we need to then to be able to see whether or not, how close we are with those assumptions.
Yeah, I think that's reasonable. Sometimes on the fertility side, some of those costs can be, interesting to capture. But I think over the next few months, we can start working with the carriers to make sure that we have that process
that you're collecting
identified.
Yeah.
Yeah.
Excellent. Thank you, Brad.
Absolutely.
Okay. Are there any more questions or anything else that I can help with?
This is Bill. I'll just chime in on one thing. And I know we talked about it in the past, but I'll repeat it again for the innovation work group thing on the Center of Excellence stuff. This is something that needs to be sold to the membership well, because it will be easily spun into a real negative politically and in people's minds, and needs to be sold out as now, like way early before it comes into play, that it is for not just a cost savings to the insurance plan, but also to the better benefit of the member and how it affects the member positively. This kind of push needs to happen before we bring it into play. That it's more to it. And this is not just we're going to inconvenience you to save some money, right? So there's more to it than that, and it needs to be pushed out as there's more to it than that.
Yeah, appreciated. Yeah, for sure. Really focusing on the quality and the outcomes and the experience of the members.
Yeah, again, it's cost, quality, and service.
Yep.
What's the impact on cost? What happens in terms of the clinical outcomes, and how
I'm just saying we know that here, right?
Yeah.
But the members are going to see it as you're inconveniencing me to just save a buck, right?
Yeah,
and they need to understand the whole thing.
Yeah,
right?
The communication piece has to be built around all three elements. I agree 100%, Bill.
I just wanted to chime in. This is Ali. I think those are great comments by Bill, and I couldn't agree more as well. And we will actually have that discussion this afternoon at the board meeting. So I would encourage you, Bill, to raise that point. Thank you.
Any other questions for our consultants in regard to the report? And if not, then we can, then it's okay for just general comments. Rose, I would like to have the executive summary, basically pages 4 through 9, added to the end of at the presentation, the SEOW report. I think that the board should see that. I don't think the whole board goes through the detail of this report, but having I would like to be able to, during my SEOW report, I would like to be able to highlight some of those, some of the data that we just had presented. Is that possible?
Sure, no problem.
Okay, thank you.
Tom, I think that's a great way to use the executive summary. Good idea.
Yeah, thank you. Okay, it is, we've actually ended remarkably ahead of time. And so my guess, Glenn, you can tell me, but my guess is that we have WW and a WebMD coming on at their specific times, which are at 11 and 11:30. So they probably are not present for us to be able to do anything with at this point. Is that correct?
Yeah. Well, let's see if more.
I mean, because the other option is just for us basically to adjourn until 11 o'clock and start up again.
Well, let's see if Maureen and Melissa Voigt are here right now.
Okay.
Let me just check. Well, they aren't. I can email them. I know they said they could start earlier, so let me email them right now and see if they're available. But we could adjourn.
Yeah,
So,
I think let's keep the schedule that we have.
yeah.
I think everyone can instead of having a 15-minute break, a 40-minute break means that you get to do your other. For those of you who are working, means that you can do some other work before we restart at 11. For those of us who are retired, it means we can go have a longer walk with the dog.
Okay.
Is everyone okay with that? For committee members?
I'm great with it, Tom.
Okay.
I'm okay either way. It's all
Okay.
good.
All right.
Even though
so
I
let's
don't
get-
have a dog.
Yeah, well, you can go out for a walk you can walk yourself.
There you go.
Beautiful outside. Okay.
It is.
So we are going to adjourn until 11 o'clock, and we'll get started with the last of our agenda. Thank you, Doug, as usual. Excellent presentation. Brad and Jenny, thank you so much for organizing this. It's always helpful, and I think we have some good ideas of how to move forward.
Well, thanks. I appreciate everybody's time today, and good seeing everybody on at least on camera.
Okay.
Sorry about the glitch earlier on my
No problem.
activity. Take care.
No problem. Go walk your dog. Bye-bye.